Hi, everyone. I'm Dr. Mario Scradiano. I'm a cornea, cataract, refractive surgeon in Chicago, Illinois. And I'd like to thank you so much for tuning in for this lecture regarding MIGS procedures in the cataract refractive patients. I have no financial disclosures to disclosed here regarding any of the products that I am discussing in this presentation. So a quick overview of the glaucoma procedures that we're doing nowadays, and specifically the minimally invasive glaucoma surgery that have been developed over the past decade. We're going to do a quick review of what is glaucoma itself and how many patients and populations is being affected in the United States. We're going to talk briefly about patient selection, as well as my algorithm for surgical decision making, which procedures to use in which patients, and also a few case presentations. And then at the end, we're going to talk a little bit more about lens selections and billing. So as we all know, glaucoma actually can be very devastating, and from my experience in residency, I remember that the glaucoma patients were some of the toughest ones to deal with. I felt a lot of times that, we're kind of waiting to see if glaucoma is going to progress, and we're always kind of debating: are we doing enough? Are we not doing enough? Is the patient progressing? Are the patient taking the drops? Are they compliant? There's always cost issues involved, so there's always something going on with the glaucoma patients, and it almost felt like there was an impending doom that all of a sudden the patient progressed, and we needed to do something more aggressive there. Now, we know the glaucoma is affecting the optic nerve. Over 3 million people in the United States have glaucoma, and over 200,000 or more per year actually receive this new diagnosis. It is the leading cause of blindness in the adults over the age of 60, and it typically occurs due to high pressure inside the eye that puts pressure on the optic nerve, and which progresses over time. We have an estimate of 4 million patients in the United States that have open angle glaucoma, and some of these are actually going blind every year. Now, who is at risk for glaucoma? Now, there's patients that have a family history for glaucoma. There's certain medical conditions that also put somebody at an increased risk for glaucoma. Anybody that has over age of 60 could potentially have a more sluggish, drain of the aqueous fluid inside the eye. Anybody over 40 in the African American population could be a risk as well. Some other African Americans, Russian, Japanese, Latinos can also be at a higher risk as well. Patients that also have thinner corneas can be more sensitive to the pressures as well inside the eye, or we know that the pressure that we measure is falsely lower, so their actual pressure inside the eye is higher. So we have to take that into consideration. Also, patients that have been on steroids for a prolonged period of time, they can also be steroid responders that will have a higher risk for glaucoma, and also patients that have had some type of trauma in the past that will lead to possibly some scarring, collapsing of the Schlemm's canal, trabecular meshwork, collecting channels that would also lead to glaucoma over time. Now, just to break it down really quickly, we're not going to spend too much time on defining any more glaucoma here. We have the primary open angle glaucoma, which is the most common form. And then we have the angle closure glaucoma, which is the least common one. I tell my patients this is the angle closure is a condition that happens, especially on our younger patients and our hyperopes, that we need to do laser PIs in order to have those accessory drain holes to the drain. That way, passageways to the drain. That way, that we're not going into an angle closure scenario. The first signs of glaucoma, as we all know, severe eye pain in angle closure specifically, severe eye pain, redness of the eye, blurred vision, nausea, vomiting. There's visual disturbances, the blurry vision, the halos, and this will lead to progress to blindness very, very quickly. This is a true, ophthalmological emergency here. And then we have the open angle glaucoma, which I tell patients it shows up like hypertension. There's no symptoms that you notice at first until there's gradual progression and loss of peripheral vision in both eyes. One eye doesn't more than the other. They don't have to be symmetric. And all of a sudden we have this tunnel vision appearance to our vision on peripheral vision exams. The diagnostic testing that we have to do when diagnosing glaucoma and documenting everything, obviously visual acuity, obviously we have to look at the optic nerve, the disc size, the CD ratio, doing an OCT or an HRT of the optic nerve and looking at the density of the RNFL layer, looking at the pressure of the eye, looking at the pachymetry of the cornea, looking at the visual field are some of the most important parameters that we need to do. Also looking at the angle itself and doing gonioscopy on your exams and evaluating for narrow angle structures, evaluating for how open the angle is, synechiae, iris processes, and all that. Obviously doing also dilated exam and taking a really good look at that optic nerve disc and CD ratio. We know there's also secondary causes to glaucoma. There's neovascular, there's uveitis, uveitic glaucoma, pseudoexfoliation, pigment dispersion. All those scenarios have to be taken into consideration because certain procedure here doing for glaucoma surgery will actually respond better to MIGS and specific types of MIGS than some other ones. Now looking at the aqueous fluid and outflow, as we know, the aqueous is being produced by ciliary processes, which travels around the lens and around the iris over there through the pupil and drains into the angle of the eye. The conventional outflow is the most common outflow for the draining of the fluid. And so leaves the eye through the anterior chambers, through the trabecular meshworks, into the Schlemm's canal, and then after that into the episcleral and conjunctival veins. This accounts for about 70 to 80+% of the drainage. There's also the unconventional outflow, which the aqueous humor just exits through the root of the iris, through the ciliary muscle bundles, and into the suprachoroidal scleral vessels. And this it's 5 to about 20%, 30% or so of the outflow. So looking at the standard way of treating glaucoma, the glaucoma medications, we all know about. We talked about how there's single mechanism of action drops with PGAs, beta blockers, alpha agonists, carbonic anhydrase inhibitors. There's rho kinase inhibitors now, nitric oxide releasing agents. There's also miotics that are not as commonly used anymore. But then there's also these combination drops. They have been used for years, which have been very, very effective for our patients. From a surgical standpoint, the filtering procedures with tube valves and shunts, and then the trabeculectomy have also been commonly used. But these are very high risk procedures. They're almost like a last resort for the patient because of the recovery, the potential complications, and all that associated with the surgery. So life altering type of a procedure that everything goes okay, everything is fine. But if things don't go according to plan, then the patient does take quite a bit of time to recover from that. The challenges of the standard way of treating glaucoma. Obviously, the most common one is non-compliance to the medication regimen. And about 90% of that, we all know about 90% of our patients, as high as 90% will miss drops throughout the lifetime. Just physically impossible for the patients to remember and be adherent 100%. About 50% of our patients will actually stop taking drops altogether for some period of time during their treatment. Then we have to reason why this may happen is due to tolerability issues. These long-term exposure to the glaucoma medication will cause some type of a corneal surface damage, keratitis, blurry vision, tearing, redness, irritation. They also possibly have some taste problems as well. So these are some of the reasons why patients will stop the medication. Cost is a big problem as well in coverage of these medications. That the patient will stop taking the medication. And then we also talked about the high risk associated with the invasive surgery, filtering tubes, and trabeculectomy. So what we're trying to avoid by intervening early is to offer, improved lower IOP inside the eye, low risk, higher efficacy type of procedure that by intervening early, it prevents the damage to the optic nerve progressing to the point where patient will need these more invasive, high risk procedures. These studies shows that in a 12-month retrospective study of 2,440 patients older than 65, more than 23.3% of patients were actually not adherent to their medical therapy. And then patients prescribed were required at least 2 drops per day. And over a 12-month period, the number of patients that actually ended up stopping their drops was higher with patients that required 1, 2, or 3 more drops specifically. So just shows that over time, in a year period, a patient will stop or they will miss drop. They'll be non-compliant to their glaucoma medication. So more of a reason for us to do something that doesn't put the burden on the patient of remembering to take this medication if possible. One of the major problems with not taking the medication we talked about is ocular surface disease problem. So our elderly patients will have some decreased tear secretions. They have other medications that we're taking at the same time. And that will lead to an abnormal tear film breakup time over time. There also, these medications have an increased concentration of BAK that also lead to ocular surface inflammation, keratitis, and that's one of the major reasons patients will stop using the glaucoma medication. This is showing the nearly 60% of medically treated glaucoma patients will report some type of a ocular surface disease due to taking of the glaucoma medications there. And both, this is the this shows us progression even in patients that you know, may stay, we think they're compliant, and they say they're compliant, and we'll see some progression in their vision over time, in their visual fields as well. In the SIGIS study, medically treated patients had an average baseline immediate elevation loss of -5.2, which worsened to 5.5 at 5 years and 6.1 at 8 years. So there's going to be progression. So that's another reason why we need to intervene sooner and offer something to the patient that will get them stabilized quicker and prevent any progression of their glaucoma. So the major, some of the other major way of treating glaucoma here that has come in the recent years. We talked about the medication drops. We talked about the invasive surgery as well. But is there something else that can be done here in the meantime in order to help patient prevent them from progression, but also not have to do that invasive glaucoma surgery with a tube or a shunt or a trabeculectomy? This is where laser procedures come in. So introducing these laser procedure SLT sooner will help stabilize and clean that drain and improve the filtration of the trabecular meshwork and the drainage of the aqueous, as well as sustained release medication that we can use now inside the eye. The bimatoprost sustained release is a new medication that came on the market that actually has shown improved efficacy here, anywhere between 4 months to a few years. On average, it's about a year and a half or so. And right now we can only use it one time, but the company is working on repeat use approval from the FDA. Some of the other laser procedures that have been in the past is ALT, also, you know, the cyclophotocoagulation. Some new ones that we have been using, micropulse cyclophotocoagulation is it's becoming a new way of treating the inflow and the production of the aqueous that seems to actually work very well as well. Also doing ECP, doing the cataract surgery in conjunction with cataract surgery is also a very good procedure to consider. So closing this gap between treating the patients with drops and getting to the invasive glaucoma surgery, this is where MIGS fits in. We're trying to do something at the time of the cataract surgery, but there's also some MIGS procedure that can be solo standing. And we're trying to accomplish similar results in the disease process and stopping the progression with less invasive procedure. We try to reduce the pressure inside the eye, dependency on their medication. It's less invasive than traditional surgery, reduce the risk of complications. So higher safety here. And, you know, I like to look at these at, you know, modest to moderate type of efficacy in our IOP lowering power. And then the other most important thing that I like to think about this procedure is that it leaves the conjunctiva intact, that thus, allowing us to actually still be able to consider a more invasive glaucoma procedure in the future if needed down the line. So recently, in the last decade or so, and I remember back in 2012, 2013, when I started residency, is when the MIGS and specifically iStent came on the market and started defining the MIGS category in treating glaucoma. As I was mentioning, so one of the newer types of lasers using SLT, micropulse, in order to augment the drops that we have been using in the patient in getting the higher efficacy of their current regimens. Also, preservatives-free glaucoma drops have been becoming more and more available for patients in order to deal with the ocular surface issues. We talked about the drug-eluting implants, the sustained release, the bimatoprost medication, and also there will be more of these drug-eluting stents inside the eye coming on the market. Other ones that we have to consider here that, some surgeons will consider, blood forming type of a procedure, maybe not as easily as, minimally invasive glaucoma devices. This is more towards a little bit more of a true glaucoma procedure for somebody that's a little bit further along and that needs more help, something called with the Zen procedure with the express shunt or the PreserFlow. That's another device that's in the works right now getting FDA approval. The whole point is to, again, the goal, reduce the burden for the patient, reduce the cost to the patient, to the family, to the system, improve their quality of life, save their vision by preventing progression, and also reduce the risk of having to go through a more invasive glaucoma surgery, if possible. There are significant treatment opportunity in our patients. There are 4.3 million cataract surgeries done in the United States per year, and 22.3% of those patients are also on a glaucoma medication. So I think from our standpoint as cataract surgeons, and to be able to offer a glaucoma surgery procedure at the same time of the cataract surgery, and doing something for the patients and helping them get a little more control of their glaucoma disease at the same time is a huge benefit to the patient with these new devices. And it's something that all cataract surgeons should consider. Looking at the glaucoma prevalence here, about of those patients, 52 are in the mild category and 25% are in the moderate category. So 77% of patients with glaucoma are in that mild to moderate category. So that is a huge number of patients that we can do something for in order to help them treat their glaucoma and get some higher efficacy treatment here. And majority of our devices are approved here for this category, mild to moderate glaucoma. 5 characteristics I like to think about MIGS is their high safety, lower risk, higher safety profile, no serious complications here that we have to worry about with these devices, like risk of hypotony, risk of choroidal effusions, hyphemas, choroidal hemorrhages. or major hyphemas. We do have occasional hyphemas here that we have to deal with that does recover within the first few weeks after surgery. I do tell my patients that they may be something that we have to deal with, and if we do, then it's just going to be a few extra visits here and increasing the number of drops for a short period of time, and patients do just fine. There's also minimal disruption to the patient's anatomy of the eye, so that leaves the physiological outflow mechanisms patent. We also leave the conjunctiva intact as much as possible for any type of more invasive glaucoma procedure, like trabeculectomy or like a tube that may be needed in the future. We also intervene earlier, so in the disease process, so prevent the disease progression here, easier to use for the patient. There's the ab interno approach, which offers us direct visualization of the angle, so allows us to be very precise in our placement of these devices. And the last thing is efficacy here. Modest to moderate type of efficacy here, anywhere between 20 to 30% drop in the pressure. Obviously, that's the goal, is to get as much as possible, and based on how much, at what level the disease processes, we can maybe combine some of the MIGS devices and get a little bit more. Would get the reduction in the need for drops, or maybe some patients get completely off drops as well due to using these devices. Now, we also, know that the IOP reduction is much more inferior than a traditional filtering procedure, but also, the risk of those procedures is much higher. So a lot of patients will opt for this type of procedure first before needing to go to a more advanced procedure. The number one limiting factor here in doing this procedure is getting comfortable with the angle of the eye. The proper visualization of the angle and identifying the structures in the angle, it's going to be the most important thing here in becoming comfortable with these procedures. So just looking at the angle of the eye during your surgeries, preparing for that is going to be out of most importance here. Identifying that Schwabe's line, identifying the trabecular meshwork, the pigmented trabecular meshwork, the sclerospur, and knowing exactly where to place this these devices. Getting proper angle to the head of the patient, about 15 to 20 degrees away from you, angling the microscope down about 30 or so degrees, and getting that en face look to the angle of the eye is just gonna give you the best success in doing MIGS surgery. The MIGS devices here that we use nowadays, we like to categorize them based on the space that they're going in and which structures are we bypassing. So in the angle of the eye, bypassing the trabecular meshwork or stenting the trabecular meshwork into the Schlemm's canal, we have the cannulating, or the, I explain it to the patients, kind of like ballooning of the vessels. So we have our Omni, GAT, and iTrack devices. We also can remove a strip of the trabecular meshwork itself, and we can do that with the Omni device, with the Cahook dual blade device, with the trabectome, GAT, and the new I-axis from Glaukos. Stenting devices or shunting devices, there's the iStent and the Hydrus. Subconjunctival space devices, so forming a bleb, are the Zen, the 45 silicone shunt, express shunt, and also PreserFlow that's currently going through through the FDA studies. So we'll see what the results of that will be. And then suprachoroidal space, this is where the CyPass used to be, but it's not available anymore. And there were a few other devices in the works in that space, but I think a lot of those have actually been put on hold as a result of the CyPass being taken off the market. Then we also have cycloablation or laser photocoagulation type of procedures here. The cyclophotocoagulation one that was used initially, the micropulse nowadays that can be done as a solo standing procedure, and ECP as well, which is endoscopic internally, which can be done in conjunction with cataract surgery, but also can be a solo standing procedure as well. But that is an ab internal approach. So for MIGS selection, first of all, is the patient phakic or pseudophakic? The title of the presentation is in the cataract patient. So obviously patient has to be phakic with a cataract. So it has to qualify from that standpoint. Open angle versus closed angle glaucoma, mild to moderate versus advanced severe disease. Is this a primary surgery or refractory glaucoma patient? Are they, is the conjunctiva scarred or pristine here? Is there prior history of laser trabeculoplasty with SLT? And we know that patients that do respond to SLT actually are doing and responding very well to the MIGS procedures. The what's the IOP and the number of medications that the patient is currently on, so the severity of the disease and how aggressive. What's the demographic of the patient, the age, the race, their scarring, the wound response to wound healing. And some of the things that I do consider here in avoiding some of these in patients is avoid angle stripping procedures in the narrow angle glaucoma patients. Obviously, not getting a view, you're not going to be able to do much there. Angle recession, scarring, that's going to be difficult due to trauma. Neovascular patients, so due to diabetes, CRAOs, CRVOs, and blood thinning medication as well, that's going to cause a significant amount of hyphema. And then also patients with elevated epidural venous pressure. These type of procedures are not going to work very well in these patients, as if the episcleral venous pressures is too high. My algorithm, when I think about choosing MIGS, I look at patient, I am a cataract surgeon, but these are glaucoma patients that also happen to have a cataract at the same time. And we're doing the cataract, but also we're trying to do something for their glaucoma. So if they're uncontrolled, if their IOP is uncontrolled, still high, or if there's some progression in their optic nerve density layer, some visual field loss, there's a poor compliance to the medication or tolerance to the medication, or we're just looking to get more reduction in the medications themselves in helping the patients with their lifestyle chores. Then I think of I split the glaucoma as they're just mild to moderate disease or severe disease. And in the mild to moderate disease, if the patient is phakic with a cataract, then we'll do some type of a angle procedure with iStent, inject W, possibly hydrus, possibly goniotomy with I-axis or KDB, or an Omni procedure, or even ECP. If the patient in the mild to moderate disease is pseudophakic already, then some of these procedures are not approved in a pseudophakic patients. But the ones that are approved are the Omni, the KDB, ECP, and micropulse. And in the patients that do have severe disease, this gets more complex here. Some of these devices are only approved for mild to moderate. It all becomes a how do you grade your glaucoma patients? In the severe patients, you need something more, right? So possibly if they still have a cataract and doing something and never had something done in the angle of the eye, maybe never had SLT, that's something to consider ahead of time, see what the response to that is. But if they've never had anything done in the angle, then something could be done here to see what kind of response you get first. And then if there's not enough, then you can also consider some of the other more advanced devices or procedures. So I'll combine, some of these more aggressive type of maybe stripping procedures with the Omni or KDB, cannulating, all the way 6 clock hours or 9 clock hours, and stripping some of that, 3 to 4 or 5 clock hours as well, placing some stents, just to give more efficacy from the response maybe, and see how the patient does with their and the pressure does afterwards. If it's not enough, then we can also always consider doing a more invasive procedure like a Zen, like a bleb type procedure, like an express shunt, maybe a tube, and augmenting maybe with micropulse afterwards, or doing ECP at the same time in the surgery or afterwards. And then if still it's not good enough, then maybe patient does graduate to a trabeculectomy type of procedure if we need to do more. So this is the algorithm that I kind of run it through my head every single time I see a patient that has a cataract that we need to go to surgery and evaluate them with if they also have glaucoma going on at the same time. Then I think it's in the benefit of the patient to offer this type of procedures to them. So that way you reduce their burden, hopefully on the drops, on the reduce their pressure, so then reduce the possibility of progression there. Some of the one of the other thing I wanted to mention, some of these secondary glaucoma scenarios do benefit from stripping procedures more. I think we're going to talk about this a little bit later here as well. So in order for you to be able to proceed with MIGS procedures, there's certain things that needs to be documented properly for your in your chart in order to be able to get reimbursed properly. So you have to obviously establish the need for cataract surgery, and concomitant patient has glaucoma. The proper evaluation and diagnostics tests have to be there. Obviously, you have to evaluate if the patient is mild to moderate. Are they progressing? Are they not adherent to their drops? How well is the IOP control? How many medications are there on? What? And you have to kind of decide, are we going to do a glaucoma procedure at the same time in order to help the patient with with IOP control, with reducing their burden on the medication or the cost, and improve their compliance and their quality of life. And obviously, to avoid any more of an invasive glaucoma procedure in the future. This is the visual field progression that I always fear about seeing in my patients. So that's what prompts me to do more and more for these patients. And I think it's the role of any glaucoma specialist or cataract surgeon to preserve the patient's quality of life here, and then reduce any visual progression here, visual field progression, by making sure that their glaucoma in a treatment is treated properly here, especially if the patient is to have a cataract surgery done. Some of the most important things that need to be documented is the pressure that the patient has, their IOP goal, also what was their max IOP in the past, the visual field results there, the pachymetry, And the current patient do have some of these devices require the patient to be on a glaucoma drop in order for things to be um, covered. And then also, if the patient is compliant, is the patient is progressed, is controlled or not controlled. Some of the devices that we mentioned here, the iStent, original iStent over there, the Zen, the Hydrus, the Trabectome, the Cohort Blade, the Omni device here. So looking at a couple of cases here, shifting gears, and what I have used in these patients. So we have a patient, JW, he's a 63-year-old African-American, has a 10-year history of open-angle glaucoma, has been on latanoprost and brinzolamide, and has a visually significant cataract in his right eye. His pressure right now is 14, and his goal is less than 17. So, you know, more or less he's actually stable at this point, but he's complaining of red itching eyes here, as well as a high cost of the medication. So at the time of the cataract surgery, we decided to also proceed with the MIGS procedure in order to improve and hopefully get the patient off the drop. So why MIGS, right? IOP, is the IOP on target? Yes. You know, is the glaucoma progressing? Possibly no. But are they having challenging with the current treatment? You know, poor compliance. There's an ocular surface disease here, cost. Are they tolerating the medication properly? So this patient qualifies because they're not tolerating the medication. They are having ocular surface disease issues here. And in order to get the patient stable here and still maintain proper IOP reduction, MIGS will need to be, can also be done at the time of the cataract surgery. So angle procedures here are excellent here. Obviously, at the time of the cataract extractions in mild to moderate patients that are also on a medication at the same time. We performed cataract extraction with iStent for this patient, and his pressure is 11, 6 months out and off the medication, both medications. In patients with moderate glaucoma, so we have a patient that's 74-year-old Caucasian female. She has a 23-year history of POAG here on latanoprost and timolol, has developed a significant cataract in her left eye. Her goal, pressure goal is 15, and she's has experienced some worsening of a inferior nasal step over there with current IOP is a 19. So we're suspecting that, you know, she's either the efficacy of the drop is decreasing, or she's not taking or forgetting. She's 74, but there's some progression there on her visual field. So something needs to be done a little more aggressive here. So we did combine cataract surgery with MIGS procedure here. We know that adding a third drop probably for her was not going to be ideal due to her poor compliance here. So iStent W, we also did a goniotomy for her with the Omni device. So cannulating and goniotomy, about 3 clock hours of goniotomy, and her pressures is 11. More advanced glaucoma here. We have a patient that's 65-year-old with pseudoexfoliation and also cataract. The pressure in this patient is much higher, so mid to high 20s, and goal is to be 16 or lower. He's on latanoprost, he's on brinzolamide, timolol, and he has significant ocular surface disease from using the medication. So for this patient, we wanted to do more. So pseudoexfoliation, some of these secondary glaucoma causes do respond very well to stripping procedures here, angle procedures. So decision was made to do Omni with Hydrus in order to avoid any other type of a subconjunctival procedure here, and if needed, that can be considered in the future. So Omni was done over 9 clock hours, cannulating and then stripping of about 3. And the patient's pressure is 13 after zolamide and timolol 6 months after the procedure. And if needed in the future, we can also, saving the conjunctiva will allow us to still consider possibly a Zen or express shunt or a trab or a tube in the future. And then patients that are pseudophakic here, considering a standalone procedure. So we have a patient that is a 55-year-old African-American male. He has a 5-year history of POAG here and bilateral cataract. He's been using latanoprost in both eyes here, but his pressures is 19 still, and our goal is to be 14 or lower. He has now refilled his glaucoma drops in the last 6 months, and we do notice a nasal step advancing over there on his visual field. He admits to not remembering to put on his drops all the time. So, and he has already failed laser trabeculoplasty. So our next step here is to consider something in the angle of the eye. So standalone procedure, MIGS procedures are excellent to consider, especially if they have never done and never had done something in the angle of the eye when the cataract was performed. Laser trabeculoplasty was already used in this patient. Depending how far back, it can be repeated. Micropulse can also be considered in this patient before proceeding further to another surgical procedure. In this patient, we consider Omni. Again, I do about 6 clock hours cannulating, about 9 clock hours of cannulating and stripping about 3, and then also placing some stents in order to maximize on the outflow. One thing that I want to mention here is the micropulse procedure that is a newer procedure here, ab externo approach here of cycloblading the ciliary bodies, success of 60 to 80%, reduction about 30 to 45%, great IOP control afterwards, 72 months out. It's repeatable and reducing the drug burden, the medication burden to the patient. These patients do end up having some inflammation or some uveitis more significant afterwards. So I do keep these patients on about 4 to 6 weeks afterwards on a tapering 4, 3, 2, 1, or depending of steroids in order to prevent and deal with the inflammation and the uveitis that arises afterwards. And also I keep them on their glaucoma drops during that time as well. And then after we see resolution of the inflammation, then we continue to taper their steroids. The CPT code for the micropulse there. So combining MIGS, we talked about combining some of these MIGS procedures. So canal dilation or ballooning of the drain here, stretching of the drain, making sure we're recruiting all those, the trabecular meshwork there, and the Schlemm canal. We can also place stents. We can also remove or cut some of the TM as well. We can do ECP in conjunction at the same time. Back in when we started doing MIGS procedure in residency, the ICE procedure, which is, ICE stent, cataract extraction, and ECP, was very common to be used. And with we also consider the VICE procedure, which is a visco cannulation of the angle I-stand cataract extraction, and the ECP was a something that we were using in some more of these advanced glaucoma patients or moderate glaucoma patients. We talked about the surgical complications, possibility of hypema afterwards. I leave the eyes slightly more pressurized initially when closing the eye and making sure the incisions are sealed, and then gradually release a little bit of the pressure, wait a few seconds there, release a little bit more until you feel like the pressure of the eye is into this high teens or low 20s. And you can leave them like that for the next 24 hours and the pressure will come down. But that will prevent this backflow of any type of blood through the trabecular meshwork and prevent any hyphema layering in the AC. And the other thing we have to consider is IOP spikes. So I do keep my patients on the glaucoma regimens that they're already on at this point until they're fully done with their glaucoma, with their steroid drops, and then about 4 to 6 weeks later is when I consider removing them off drops. This is the eye access, which is a microgoniotomy here from Glaukos that was released here in order to be able to do goniotomy, microtrephination of the trabecular meshwork. This is the original, the I-stand that now it's in its third release, the W that has the wider flange over there in order to prevent over-implantation into the trabecular meshwork. The Omni device that's able to cannulate with a proline suture all the way around the trabecular meshwork and dilated as it retracts. It leaves a little bit of viscoelastic to maintain it open. We can also do goniotomy with this device and stripping of some of the trabecular meshwork and some of the preferably infranasal area. So in order to provide open access to the Schlemm's canal and the collecting channels down the line. And the Hydrus microstent, this is a bigger device here. It does require access to a side port, not your main incision, in order to get the proper angle for implantation. It's a little harder to do. It does cannulate the 3 clock hours of the Schlemm's canal there and provides and keeps it open. So it does provide open and collapsing of the trabecular meshwork over time by recruiting those 3 clock hours, and hopefully, there's active collecting channels downstream from there that will help with draining of the fluid. This is a little bit tougher device. I think the learning curve on this is a little bit more than just the I-stand. So we do consider this in more of our advanced, moderate plus glaucoma patient as well. Combining MIGS here, there's a new train of thought where the trabecular meshwork does act like a mechanical pump and pushing or pulling the aqueous humor as well and aqueous fluid and pushing it downstream. So for that reason, stripping too much and preserving some of that instead of preserving that tissue here for preserving this natural way of outflow. So cannulating it, but without stripping too much. There's this new thought that we're still investigating here in order to be able to maintain that mechanism. So for that reason here, some of the secondary glaucoma, they do better with stripping procedures versus, and some of my other patients, I still like to preserve this tissue here. So then just cannulating it, not stripping too much. So then that way we're preserving this mechanism of action. the stripping of the trabecular meshwork does work very well in our juvenile glaucoma, our pseudoexfoliation, pigmentary uveitis patient. I also mentioned here bleb forming or MIGS procedures can be used standalone, and they obviously have higher efficacy as well with Zen, with Express Shunt, with PreserFlow in the future, hopefully. But managing of the conjunctiva and the tenons and reneedling of these blamps is more involved in about 32+% of patients. So it's a little more involved than our other MIGS devices. In using MIGS with premium cataract surgery, so I still consider using advanced technology, IOLs in these patients. Definitely use toric and astigmatism correction lenses. As we know, contrast sensitivity is one of the major downfalls. When the glaucoma is progressing, patients start to lose contrast sensitivity. So in your moderate patients, it's best to use monofocal IOLs. You can use eye-hands, you can use light adjustable lens. In your mild to moderate, I still consider using some EDOFs, and especially Vivity as a more forgiving lens. And in our with our multifocal lenses is the ones that we have to be the most cautious about, because these lenses are known to reduce the contrast sensitivity, especially in the foveal region. So as a result of that, I don't really put these in my moderate cases, maybe in some of my mild cases of glaucoma that we know patients are going to do okay over time and still benefit from using one of these multifocal IOLs. In wrapping up over here with billing in June 10th of 2020, the CMS, they did some modifications to the billing codes. Here, the stent placement code, T code, has been eliminated, and 2 new codes have actually, CPT code, have been released in order to combine the cataract and stenting procedure. The 2 codes, the 66174, which used to be the canaloplasty or the cannulating of the trabecular meshwork, and the 65820, which is the goniotomy code, cannot be used in at the same time if done with the same device, which has been a major change here in coding for some of these devices. We talked about the goniotomy code here. This has to be used first, as it's the higher payer paying code, and the second one is the cataract code, which will be reimbursed at 50%. Some of the other codes here that we use for some of the other procedures, if we do goniotomy alone, ECP with phaco, there's regular cataract and complex codes as well. The Zen codes, the cyclophotocoagulation code as well. The other reason to consider introducing MIGS into your practice and offering MIGS to your patient is the part of the reimbursement part is that these are the changes that are happening and has happened since January of 2022. So if we look at the doing goniotomy here, we see what the reimbursement is for that code, and the secondary procedure being the cataract itself. So it significantly increases our reimbursement for those procedures. Versus just doing, this is combining mixed procedure versus just doing a trabecular meshwork stent implantation procedure due to the bundling of those 2 codes over there. the second part of that slide there is more or less is for physicians that do operate at a surgery center, and if they are also partners over there, then their reimbursement is due to the facility fee is significantly increased. So why consider MIGS here in this newer technology in the glaucoma space is to help something and do something for your patient in preventing progression in their glaucoma, but also doing something is also something that will also help your practice. So considering, you know, SLT, micropulse, some of these sustained release medication that can be placed inside the eye. But especially with cataract surgery, we have one opportunity of doing something for the patient. I think the goal here not to miss on this opportunity and offering something for their patient. I have a lot of patients coming into my practice, sometimes for a second eye, and now they want something done because they've heard about these MIGS procedures and they want something done for their glaucoma, and they haven't had it done in their first eye first, or patients being sent because of the MIGS procedure that we can also do at the same time of cataract surgery. We can also obviously consider the standalone procedures as well with MIGS, which is also a very good tool to use in your patients that are not controlled from the glaucoma standpoint. And then the other important thing is how to capture more patient. And so talking to your referral network over there, some of the optometrists out there do not know about all these new options on them that are available for patients nowadays in order to help IOP reduction and prevent progression of glaucoma. The most important thing is talking to them about maybe some of these complications or post-op management that can happen in order so they're aware of this, especially if you're going to be co-managing with them, so then that way they're not surprised or holding on to these patients that are a little bit more that may have some of these complications, see them the next day and send them back to them afterwards if you are co-managing in your area. I hope this has been beneficial in reviewing some of these MIGS procedures and how I use them in my practice, the algorithm that I use in my patient, and a lot of the glaucoma right now in these procedures, we're still getting their efficacy. We're still kind of using them in combination with each other. So each patient will be different, and tailoring the way you treat the patient, each patient will be different from patient to patient as their need and progression here is obviously different. So the using a combination of these is beneficial, and just starting to use one device here, the eye stand or the goniotomy, the eye access procedures, the Omni. So then getting used to working in the angle of the eye will be beneficial in offering MIGS procedures for your patient. Thank you so much for listening, and I'll be available to answer any questions through the email if needed. Thank you.